Good evening and welcome to this evening's Royal College of Surgeons of Edinburgh webinar. The topic we're going to discuss this evening is redeployment of dental staff during the COVID-19 period. This is a topic that affects the whole dental team, and certainly amongst our own staff it has brought a degree of anxiety. This will be an informal style of webinar, a discussion between the panel, and we have three speakers to talk to you this evening. The first person who's going to talk to you is Helen Stancliffe, who's a clinical teaching fellow and specialist oral surgeon here in Newcastle, with extensive experience in oral maxillofacial surgery. Helen is one of our early career ambassadors, and in Newcastle she's taken the lead in providing update courses for dental staff in Newcastle for readiness for redeployment. We also have Natalie Bradley, who's a special care dentistry registrar in London, as well as being one of our college dental ambassadors. She's also a regular dental blogger. Natalie is currently redeployed and will give us some insight into her experiences. We have Mark Tawadros, who is from the British University in Egypt. Mark is an international dental ambassador for North Africa and the Mediterranean region, and will bring an international take on the current situation. In addition, we have Richard Cure, who is the Dental Faculty Convener of Education and an Associate Professor in Orthodontics. Myself, Ian Corbett, and I am the Convener of Dental Examinations at the College and a Consultant Oral Surgeon. Richard and I are predominantly going to be here to field your questions to the panel, although we're happy to join in should you like to ask us any questions. We unfortunately won't be able to answer all of your questions, although we'll try to do as many as possible. And I'd be grateful if we could keep the questions to the topic that we're trying to cover this evening. If we can't answer your questions, we'll certainly record the questions, and hopefully we'll be able to provide some further information and links in the next few days to try and cover any topics we didn't manage to cover this evening. The webinar will also be available on the college website in the next few days if you wish to review it at any point. So without further ado, I'll hand you over to Helen, who will tell us a little bit about readiness for redeployment. Thanks, Helen.
Hello, everybody. So I've been asked to speak to you about what we've done in Newcastle in terms of redeployment. So in our centre, before any of the guidance really came out, we tried to get a little bit ahead of the game in terms of the planning of what we were going to do with our staff. So to start with, we kind of looked at various different team members to see what skills we might be able to enhance for them to help them before they consider their redeployment. So I was tasked initially with kind of coming up with those different staff groups and then organising some appropriate training that might help them before they go into those roles. So my initial kind of tack to it was starting with the staff that we thought were going to be most likely to be redeployed to even within our own units. So mainly using things for the maxillofacial services. With our service at the moment, we've only got a set number of staff that cover our on-call services. So we wanted to really bolster our team as a reserve so that they're ready to take over as necessary. So to do that, we basically started to run our own mini version of the Dentist on the Ward course. So this involves going through basic training in kind of management of the admission of patients, taking people through from attendance all the way through to admission into a hospital bed, how to officially clerk a patient into hospital, including doing kind of maxillofacial examinations through to the medical examination of the patient. All of that as well brought in the additional ward skills that you might need. So going back over venipuncture, cannulation skills, reinforcing our ANTT training from the trust. We also did some work on suturing, so things to do for predominantly suturing for head and neck wounds, but how that would apply to other wounds in the body as well. Different work that we did was, a lot of it was based on IT, as our local service has moved completely paper-light in our main hospital, but not in our dental hospital. So it's trying to give them the skills that they would need to be able to complete any tasks online, so be it the ordering of bloods, prescribing of drugs, everything that our SHOs basically take for granted. Other things that we did, we kind of had the involvement of different teams within our hospital because we recognised that there were different skills that we could pass on from the teams. So we have based here our own theatre suite, so we could use our nursing colleagues to be able to teach some of the advanced ward skills for the staff. So this involved doing things about kind of management of arrest patients, how to access the crash trolley and what's involved in using the various bits of kit, just to make them more familiar about it, how to carry out set obs on the ward and how to record that with a news chart and what the different parts of that meant, things about how to set up an IV giving set, how to operate hospital trolleys, simple things that we kind of know the basics of within our dental staff, but we may not have put it into practice, or it's been a while since a lot of people have put it into practice. So the main focus of that for the first few days was really training up those junior staff, so we had our backup reserve ready for on-call. Moving on from that, we then moved on to our more senior staff who have worked in obviously different fields of dentistry and felt that they wanted a little bit more of a refresher in some of the things. So predominantly for these people, it was related to doing kind of cannulation and venipuncture. So a lot of that training went into that. A lot of the guidance that's gone out at the moment has talked about people who've done stuff within the past couple of years. So it was to make sure that we kind of updated those skills so everybody was doing cannulation on models and on each other, just to refresh skills, ready for redeployment as required. Other bits that we've done, so we're also one of the urgent care centres for the North. So over the past kind of month or so, we've taken on the responsibility of managing dental services in our region. As it stands, we haven't really had a need to have any redeployment to our own centre because we have quite a lot of staff that would be based here. So we've been setting up the service locally, and then things have been changing over the recent days as other services have come online within the region. So it has been a bit of a transformation within the hospital for how we manage the team. At the moment in our own team, we have already had some areas of redeployment, predominantly with our DCPs. So already on a voluntary basis, some of the ones that were not involved in our emergency clinic have been redeployed to doing swabbing within the pods, testing for COVID-19. So a lot of those are already on the shift pattern and have so far been reported that they've been quite happy with the procedure. They've taken to it like ducks to water. Most people are really quite happy just to feel like they're doing something active, whereas lots of people have kind of been waiting for this to happen. Other members of staff, we've got some that have been redeployed to the supplies companies, to the chains there. We've also had some of our university staff redeployed to help with some of the COVID research. So some of the teams that would be involved in research within our hospital have already been redeployed to another trust to help with that. Okay.
Excellent. We've had some questions there. I think what we'll do is we'll move on to Natalie, and if you'd like to tell us about your experience, because I think some of the questions you've had so far relate to what you'll be telling us about. So.
Okay, so I've, because I work in several different sites, it varies depending on where I work, how the redeployment is being handled by each sector. I spend, I spent all Easter weekend actually in an urgent dental hub, from being redeployed there as part of the community dental service. And that is the service that gets patients directed to it via the 111 service. And that is seeing patients who have urgent dental needs. Unfortunately, we don't have all the PPE that we require at the moment to be able to do the full complement of dental procedures. So we still are having to refer onto a separate hub who have the appropriate PPE to carry out aerosol generating procedures. But in terms of the demand over the weekend, it's got very, very busy, especially over the Sunday and the Monday. Though that's because that these patients don't have dentists, or their dentists aren't taking the calls over the Easter weekend to do the AAA advice. So we're having to pick up the slack. But the majority of patients that we see, we try and avoid actually physically seeing them. So patients are directed via 111 and booked in, but we don't actually physically see them unless we have to. So we perform remote consultations via telephone, give them advice over the phone, remote prescribing, which involves a lot of logistical management, finding pharmacies that were open over the weekend and able to accept remote prescriptions. and directing patients there, or otherwise getting their details and referring them on to other hubs which have the appropriate PPE to carry out aerosol generating procedures, or bring them in to take teeth out, which we could do. So that's one of the hubs I work at. One of the other hubs that I currently work at in the hospital has not yet been set up. It will eventually be a hot site. So it will be potentially seeing patients who are have suspected COVID symptoms, or are living with people who have those symptoms, or potentially COVID positive patients. This is based in the hospital, and we have all the correct PPE, fortunately, but we haven't yet had that pathway solidified yet. We are working with commissioners to set hubs up across the south, and it's taking longer than anticipated because of the difficulties in getting PPE across to the hubs, and also not only getting the PPE in the first place, but getting the facilities to be able to fit test our staff. It's not just training someone to be able to do the fit testing, it's getting all of the kits, like the hood, which are difficult to get hold of at the moment, unless you're based in acute trust. I think they're prioritising acute trust for obvious reasons. So that's why there's been a delay in the area I've worked in. So in the meantime, in secondary care, we are fielding patients from who aren't our hospital patients, who are calling us in need, and we will see them after following triaging and assessment over the phone. We also have access there to video consultations by NHS Attend Anywhere, and so some of our specialties are using that facility to assess patients remotely. Obviously, there are some specialties that will lean towards that method of assessment more than others, and being a special care dentist, it's very difficult to remotely, well, it's difficult sometimes to even assess someone who physically comes into the surgery, so it's a bit limited in terms of what we can provide in my specialty. But we are seeing all patients really, and while there are several specialties working out the same department, we are pretty much seeing each other's patients whenever we need, because as we are kind of on an unofficial rota system to minimise lots of people being in the department unnecessarily, and in case to plan ahead in case people are having to self-isolate in the future because of sickness. Our nursing team there have a lot of them have been redeployed already, so we've got a skeleton service in terms of our nursing support team. Many of them have been redeployed, similar to what you just said, Helen. They've been redeployed to do the swab testing, to help on A&E, and to move PPE around the hospitals. So we don't see, or they always come up to see us in the morning, and then they get redeployed from there. So it's not, they don't necessarily know where they get deployed to until the day that they turn up to the dental unit, and then our matron says we need this many people to go down to A&E today. In terms of the clinical staff, there are plans to redeploy some of us throughout our trust as well, because it's unlikely that all of us will be needed to work in this hot hub, as it's anticipated that there are not going to be that many patients coming in who are hot, who will need urgent dental treatment. So we have all been designated a slot on a similar course to what you were saying, Helen. So refresher of cannulation skills, and taking obs, minipuncture, proning as well. And I know some of my colleagues in other hospitals have already been pulled from other units in MaxFax, for example, who go to help prone on the ICU. So it's being fluid and helping out if possible. But I think, as I echo Helen, it's finding ways that you can be useful in one way or another, rather than sitting there waiting for patients to arrive through your door, especially in the unit where we don't have the urgent hub set up yet. We don't have an official pathway. So until that pathway gets put in place, patients are few and far between at the moment. But then I guess there already word has got out that we have the correct PPE and we are seeing patients. So it's steadily increasing, which is good, because that means that we can actually see patients who need seeing, and we're using the right PPE, we're able to do that. It's just then we want to make sure that we are not unnecessarily using PPE as well. While we have patients in the hospital who are in ICU confirmed with COVID, they need the PPE first rather than for us to treat dental problems. Although it's a priority, but the priority remains with those staff, I think. Ian, you're still on mute.
Thanks, Natalie.
Okay. Sorry about that. Just to clarify, we talk about hot patients or COVID positive patients, and cold patients are not known to be positive. And we also have a separate category called shielding patients who are immunocompromised in some way. And we tend to deal with all three in a slightly different situation. We've had a question from Visna Perner asking about how we implement changes sort of structurally within the hospital to manage the patients, as a lot of chair arrangements are close together. Helen, do you want to comment on how we're running the service in Newcastle?
So at Newcastle at the moment, we've already established the service to kind of cover all of the hot patients, warm patients and cold patients. So we have the benefit that we have a large centre, so we've got many floors that we can direct our patients to. We're predominantly triaging the patients through 111 rather than having patients that would traditionally have arrived on a morning basis to attend our emergency clinic. In this way that we can give our patients appointment times to limit the timings where our shielded patients might be attending, to avoid the times when our potentially COVID positive patients could be attending. We have a separate site, so a separate floor to treat the patients that are suspected of having COVID, and they are taken in a very kind of whisked through process to get straight into isolation to minimise the contact with any other members of the public or any other members of staff. And we have staff that are prepared there waiting with the appropriate PPE to take those patients. With regards to our shielded patients, we have a separate area on a different floor as well, where those patients are kept away from everybody else. We have our waiting room set out where the chairs are demarcated to keep people appropriately socially distanced. Our main centre is on a different floor completely for our cold patients. So for those patients that are not suspected as having COVID and are not shielded in any way, in another way that we can keep them separate, and also the stagger the patients throughout the bays so that people aren't having direct treatment next to each other, to also minimise risk.
Helen, could I just ask on that going forward? I mean, I think we all realise now that we're going to have COVID-19 for quite a while. Do you perceive that these changes are going to have to really be pretty much at least semi-permanent, if not permanent?
At the moment, we're still looking at our rotas almost on a week-by-week basis. We've now created a centralised core team that have been allocated to not be redeployed, that we've deemed essential within our own trust. And we also have a backup team that's ready to take over should we have any problems with illness. Beyond that, at the moment, they haven't got into the long-term planning because it does seem very, very unclear still what might happen. So there's still kind of queries over what might happen long-term with annual leave or with staff of rotating them, just to give some more staff time at being at the front line and give a rest for the other staff that are currently working.
Thank you.
We've had a couple of questions asking about online dentist on the ward type courses. Are any of you aware of any courses that are available online?
Not at the moment.
Yeah, I guess we have some of the courses are online from the WHO. I've been attending some of them, and also some of the maybe Harvard University about COVID-19 and how to act when you're in this situation, and how to be prepared, and all things you have to know if you once can be volunteered or volunteer for such a situation.
How successful have those courses been, Mark? Do you think that they're appropriate and at the right level?
To be honest, I'm never was in such situations, so I was looking for any chance to be prepared. But mostly I can say they were appropriate to a good level, but they might not be so informative of how you can manage and how you can act if you are in this situation. Like, you have to get another, I think, if you once redeployed or volunteering in this, you have to get another on-site training or induction about how's it going, because I think like every place and every hospital is different than the other, and the way they manage this, you have to have another induction, I think.
Thank you.
Just coming in on that, if you read the guidance that was released by the Office of Chief Dental Officer on the 9th of April, days are blurring together, I can't remember what day it is today, to be honest, that there is a flowchart that says that it's mandatory to have appropriate induction before you're redeployed to an area that's not dental, and so that should be put in place by the local trust or organisation, similar to what my trust is trying to do, and Helen, what yours is trying to do. So I guess it's, if you are going to get redeployed, it's relying on the organisations who are redeploying you to provide you with the appropriate training.
I think in most regions it should be possible to arrange local training if you find a friendly physician or a max fac surgeon who might be willing to provide small training courses. Certainly Helen sort of volunteered to take on that role and has dealt with most of our staff in the hospital. So I think that there's probably somebody out there who you can approach to try and organise a local course if there isn't one available. We've had a couple of questions regarding protective equipment for redeployment of dental services. And really, that is something that is on a local level and a countrywide. So you really need to look at your local guidelines and your national guidelines that have become available on what level of PPE you need for each of the procedures you're doing. In Newcastle, we're avoiding most aerosol generating procedures, and we are using appropriate PPE according to our hospital guidelines. There isn't particularly shortage of PPE that we're using. And we make the best use of that. So if you wear a mask, you wear the mask for the whole session, just to reduce turnover and numbers of masks used. I think that's really all we'd like to sort of discuss about a PPE level, if that's possible.
Maybe if Mark just talks about what's happening more specifically in Egypt for a few minutes, Ian, and then we can just go through some questions again. Mark, do you want to update us?
Yeah, sure. So in our country, we're mostly we have a partial lockdown in our country. So most of the clinics and universities and schools, everything are shut. But we still have some of the clinics who are able to have some PPE and availability to protect themselves, are doing the emergency procedures. Other clinics are doing the teledentistry or online or consultation by phones, so that they pick up who really needs a dental checkup and an intervention and who doesn't. But the routine dental procedures are so they're not carried out now by most of the clinics. We're following the guidelines of mostly the WHO, and we have some guidelines from our Minister of Health and our syndicate. We have to update our guidelines by looking after some of the UK guidelines that are so helpful for us. I think that 1 month ago, regarding the redeployment and volunteering, 1 month ago, the Minister of Health published a form so that all the dentists and even the non-medical staff can fill in this form, and who are really want to volunteer one day if it has the healthcare needs some help. So actually myself, I filled in this form, and after few days I got a message from them, and they said that they're gonna call if they need help one day. So actually, we have a good chance for voluntary act in this because most of the clinics are shut down, and the university as well, like the academic stuff also. I think they have transferable skills when it comes to supporting the healthcare in this. Most of the universities are working on an e-learning platform, and the workload is not that big. So I think that we can have a support if they can help and volunteer. I think also the clinical attachments and the programs, all of them are shut down and nothing is carried out. We, like most of the hospitals or the dental hospitals, are limiting the visits to the emergencies only. And then I think that the skills that are transferable for this, regarding the academic stuff, I think they can help out with. I think if we can find out some specialists who can give out some trainings and induction about getting prepared to help in such pandemic. And yes, I think that we have a good chance if we need some help from the dental professions. They'll be there for volunteering.
Thanks, Mark.
We've had some questions regarding redeployment and whether this is on a voluntary basis or how it's managed. Could either Natalie or Helen comment on this?
Yeah, happy to comment on that. All redeployment that we've been offered has at the moment been semi-voluntary, and they take into account, well, I mean, where semi is that you are told this is your offer of where you need to go, and if you have any issues with it, and that might be because if you're redeployed to ICU, for example, and you live with someone who potentially should be a shielded patient, or someone with a chronic medical condition, then it might be something that you and your manager could discuss, and then there have been instances where people have then been redeployed elsewhere, which can be included in non-clinical roles. So there are I'm specifically thinking of some of our DCPs who have been redeployed into non-clinical, non-patient-facing roles because of some of these considerations. But again, it's if you look at the guidance, it says that redeployment should be voluntary. And I can't remember the numbers, but from Twitter, I'm seeing someone say that had an overwhelming response from that poll that people were signing up to volunteer to be redeployed. So I think from my experience, it's been mostly voluntary.
In Newcastle, it's similar really. It's if you're based out in practice, then it should be purely voluntary. If for any reason, if you are within the hospital services, they do have the ability to redeploy you, but in a similar way, they wouldn't send you to somewhere that you were not comfortable going. So it's all within people's level of competence, but they do have the right to redeploy their staff as opposed to working out in primary care.
We've had a question about where dentists are being redeployed. Could there be a simple way of identifying them as opposed to being a medical doctor? And the question goes on as to how do you feel it's appropriate for a dentist to identify themselves to patients on the ward? Should they actually say they're a dentist or not? Any thoughts on that?
I'll just make a quick comment there. We've had some of our newly qualified doctors who've just started in hospital today after graduating this summer, essentially early, and we've identified them in the hospital with a slightly different colour badge. And that's not to sort of pick them out as being underskilled, but more to be aware that they may need a little bit of assistance and to be approachable for them. So I think something similar for dentists might be quite a good idea. Helen, Natalie, any comments on that?
Yeah, I'd say from generally, if anybody has worked as a dentist within the maxillofacial services, most people have been through that transition where they're working in a role where they don't necessarily initially feel comfortable when they're working on a ward. And we've always encouraged our staff to not necessarily stray away from the fact that they are dentists, because dentists have their own skill set that can be very, very useful in those scenarios. So it's not something that you should necessarily be hiding for anybody to say that you're a dentist, but it might just be more highlighting to people when you do need further assistance and making sure that the team that you're working with is aware of the limit of what your skill sets are.
We've had a question from Hannah Pugh, who commented that it seems to be only the salaried services that are being redeployed at present. She has some MaxFax experience and wants to sign up to volunteer, and was asking if we knew when GDPs will be redeployed. Natalie, you mentioned setting up centres in London, and we have a similar thing going on in the North region as well. Do you have any comments on that?
It's I think initially it will be where certainly how things are happening across the south is the hubs have been identified, and initially the staff who currently work in those hubs, whether they be in secondary care, whether they be in a CDS service, or whether they be a general dental practice, will be the first people to be the workforce for those hubs. There will obviously be a few people who might not be able to do that. That might be because they might have to shield themselves or live with people who are shielding. And so there has been information collected in our region for GDPs who would like to volunteer at the hubs. And it's a massive job collecting that information and making a rota. Currently, I haven't been roped in to do that job yet, but I think at some point there will be. But I think the first line is the hubs will be staffed by the people who currently work in those practices and those clinics. And then following that, there will be an ongoing rota that will be organised from the people who put their names forward to volunteer. And of course, then it's also matching the people up with skill sets, which is really important. So something we've had to take into consideration across the south is you can't just lump a foundation dentist by themselves in one of these hubs. They might be very good at what they do, but it's taking that risk of who's appropriately skilled to be able to see these patients as quickly and as efficiently as possible. Taking a history from a patient when you're already gowned up in PPE is somehow it's different. I know it shouldn't actually be different, but it just feels different. You have a different set of pressure on you. You might have the luxury of more time because we don't have as many patients booked in. So we have a patient an hour at the moment, so that we can don and doff appropriately and also clean down the surgeries appropriately as well. But if you need to be good at taking teeth out, you need to be efficient. If you are going to do an aerosol generating procedure, you want it to be for a minimal amount of time as possible. You need to be good at diagnosing all these dental problems quickly and communicating that with the patient. So it's not just lumping all of the people who want to volunteer together, it's assessing the people who have volunteered as to what their skill level is and matching them up appropriately. So that maybe in a hub, our plan hopefully is to get our people who are tier 2 credited in oral surgery to be have at least maybe a day or so at the hubs a week, so that if someone has a potentially difficult tooth to take out, you want that person to take it out to minimise the chance of it going surgical and then being an aerosol generating procedure. And so there's loads of things like that to take in consideration, and I think that's why it's taking time.
Thank you, Natalie. We've had a comment from Anne Begley on the question about a dentist on the ward availability of online packages, and she tells us that there is an available package on the e-learning for healthcare from Health Education England, which is accessible. And they also have some information on COVID on that website. So that may be accessible to most people, I believe. So.
Also, we've had a question from Alison Ray, who is asking, which Natalie, you may be able to help with. What are your local plans for managing paediatric patients?
That's a really good question. Certainly in our region, we have a shortage of people of specialists in paediatrics. In London, they have, in the hubs that I work in London, they have one centre that sees the paediatric patients and one sees adults. So they all go to that centre, and the appropriate staff who are good at treating kids, so they might be specialists or they might be level 2 accredited, or up to that skill level anyway, will be working at those hubs. And then further, in terms of across the south, the plan we have, as part of our standard operating procedure, quite clear advice when you're managing paediatric patients, especially when it comes to trauma, is that we have details for secondary care specialists who are at the end of the phone, who, if you are seeing a patient in a hub and you want advice, not just for paediatrics as well, for other specialties, collating that information and circulating it so that you can pick up the phone for advice. And also, as I mentioned, luckily we have facility for some video consults as well. In terms of patients paediatric patients who aren't very cooperative or highly dentally anxious, unfortunately, until last week, we did have emergency access to a GA theatre slot in a CPOD list ad hoc, but now that facility has, I think, has been removed. But we do still have facility to perform inhalation sedation for some selected paediatric patients, but they will only be seen by our paediatric specialists. And we also have fully disposable RA tubing and masks so they're single use instead of using the sterilisable ones. But I don't think we've had to resort to that yet, but those are the plans in place for any urgent paediatric cases who might need treatment, who cannot manage it just with local anaesthetic.
Thank you. We have had 2 or 3 questions relating to indemnity. Again, if any of the panelists would like to answer, certainly my own understanding is that individuals can contact their own indemnity organisations to make sure that they are covered, and I think that's probably the most appropriate advice that we can give on indemnity, that it is the individual who would need to just check if they have any concerns. I think, would that be agreed by the panel?
There has been the COVID 2020 Act that says that any redeployment will be covered by hospital indemnity. So it does advise you to contact your local indemnity as well. But everything that is covered, everything for redeployment should be covered by that Act.
Thank you, Helen. There's basically a question from William Fitzpatrick, who said that it appears that the numbers in the UK may be plateauing, which certainly, hopefully, is the case. And asking the question, and should we be actually focusing on moving forward whilst living with the virus? Any thoughts on that as to how that may happen from the panel, including Mark? What your thoughts are out in Egypt?
Yeah, I think like we have many dentists are trying to figure out this one because this is like while staying at home most of the time doing nothing, you think about your profession, how you can go back and do some clinical work. So like dentists, like through social media are chatting and sharing some information about negative pressure suctions and ultraviolet devices to like decontaminate and sterilize the room. And some people are getting some papers to debate this issue and whether it's going to be efficient or not. So I think like most of the dentists are trying to figure this out because maybe the wave nowadays and the curve in Egypt is a little bit flattened. We're not sure yet if it's going to be like a good thing or not in the future, but we're still like, you don't know if you're going to be redeployed or you're going to return to your routine work. So you're trying to prepare for both options. So people and dentists are trying to reach an evidence-based conclusion for an efficient way to proceed in the routine clinic and taking these procedures.
Just as a point of clarification, I've been asked whether when you're redeployed, should your any complaints go via the trust or via your own dental protection? I guess initially it would be via our trusts in the UK who deal with it, and indemnity when you're working in hospital practice is simply topped up by the indemnity organisations. It's just a comment on that. We've had a question from Jamie Deans about training for anaesthetic support and essentially working within the main hospitals rather than in a dental service. Natalie, Helen or Mark, would you like to comment on that? How you see that panning out? Is that something we're going to need, or is that something which may not be necessary in the long run?
I'd say it appears at the moment, in the north at least, everything does appear to be coming to a bit of a plateau, and we're lucky with our numbers at the moment that we're not required in the main hospital. So the hospital seems to be sourcing from within its own teams, and it seems most likely that they will draw on them into ITU. They will draw on their own teams first, and their other support before the drawers we're more likely to be used as a backup service that might be infilling in other roles where they're then deficient once they've moved staff across.
I think there is quite a lot of spare capacity, as you say. We've set up Nightingale hospitals around the country, but I think with the exception of London, these aren't being utilised at the current time. And if they were to be utilised, then there may be a little bit of a shortage of staff, but while we still have capacity in our district general hospitals, then there also is the staff capacity as well.
So one or two semi-related questions, one from Nizar Mihani, who's asking that how are we likely to manage a scenario where redeployed dental staff are required to return to their primary roles, but ICU and wards continue to require their support due to ongoing pressures beyond the peak? That's one where we have no definite answer for, but any thoughts from the panel about that?
I just think that if you look at that scenario, what is the priority? Routine dental care or managing critical patients in ICU? Or so I think if that is the case, that we will be kept in those redeployed positions. Certainly we had the conversation with the commissioners yesterday about what is the length of time that we're going to have these urgent dental hubs up and running for. If routine care commences again, does that mean they're completely shut down? And the anticipation that it will probably be ongoing beyond that because of the risk of another peak after lockdown is lifted, that there could be a resurgence again of infections. So that is the plan. And also in terms of what workforce we have left as well. I mean, that sounds quite morbid, but there are going to be people who don't survive this virus. And does that mean that we need to reevaluate our workforce from scratch?
And another sort of comment, which is sort of going along these lines, saying that out of all the NHS services, probably head and neck related services will be the specialty that will take much longer to go back to normal. In other words, all of dentistry. as opposed to maybe medical specialties like orthopedics, etc. How as a profession are we planning for this? Probably the answer is a bit like Mark answered before, that we're all sort of trying to gather as much information as possible and follow the evidence as best we can, the scientific evidence. But certainly, I think it's going to be more of a challenge for probably primary care practices to sort of get back to a normality than probably some hospital departments. Not that I'm saying one's more or less important, but I think in general terms, it's going to be a challenge for primary care dentistry. Mark, would you say that? I mean, a lot of Egypt is non-hospital based dentistry, isn't it really?
Yeah, I think that this is the case in Egypt. Like, everyone is trying to figure this out and looking for a way out for this. I think it's the same. I
think we will see quite a big backlog of patients when we return to work. I think we're going to have lots of extended waiting times throughout all specialties, let alone max fax. I think it's going to take quite a long time to address that. We're talking years rather than sort of something we can deal with in the short term. Certainly, we're going to possibly need more staff. Funding might come with that. That would be good. Otherwise, it's going to be long working hours for the rest of us.
Yes. One question going backwards a little bit from Alexandra Rawlins is that relating to are there any redeployment roles that might be appropriate for dental foundation trainees who would like to volunteer? Maybe Natalie or Helen on that one?
Yes, there are. Certainly in London, our dental foundation trainees have been already redeployed to the Nightingale Hospital. They're mostly desk coordinators, which is mainly a non-clinical type role. So there are roles that dental foundation trainees can do. I also know that certain areas of the country are really short of 111 call handlers. There's a lot of pressure on 111 at the moment. I mean, certainly one of the patients I spoke to at the weekend said they were on hold for an hour just to get through to a clinical advisor. And that is a role that you could potentially do at home, and depending on which call centre that you it's not involuntary. I think they will even pay you to do this. And there are different levels of clinical advisors. One's from you don't have to have any medical qualifications at all. You're following algorithms to specific dental ones. And our 111 service has actually approached some of our dental nurses to request if any of them want to be redeployed to them and to help take the load off them. And so there are plenty of opportunities for all skill mixers.
I was just reading in the BDA newsletter today about some dentists in the London area who have set up their own help service, providing care packages for accident and emergency staff, just providing them with a shopping service and basic food packages just to keep them going and they're working long hours. So some people are taking the initiative and setting up their own service. There is a website where you can sign up to be a volunteer, but it's just had so good a response that there aren't jobs for everybody who wishes to volunteer, unfortunately. But it's nice to know that people want to volunteer.
Yes. A question stroke comment from Carlos Ibrahim, who said, and again, probably to our panelists, would it be suitable or appropriate to allocate academic trainees of different dental specialties to provide structured online training for redeployment skills scenarios? And if so, could this be organised by deaneries? So I think, I know you can't answer the latter one, but Helen and Natalie, and Mark, do you think that would be an appropriate way to go?
I time, I am already academic. So yes, that's what I kind of took upon myself to do already, just kind of working under the advice of our dean and also through our trust. But I think it probably does need to be done on a local level. It would be quite difficult to do that nationally.
Okay. Yeah.
Yeah, I think the same here. Like I think it's possible and would be very beneficial if it's organized. I think more cooperation would be necessary between the different, not only dentistry, because like the dental knowledge is not enough for being in such situation. You have to gain more knowledge and to know how to use your skills and the dental skills in these positions. So I think that like more cooperation would be necessary to organize an appropriate course that would be appropriate for the dentist to be ready with and to start and take it as a start if they want to volunteer.
We've had a question from Fiona Elwood asking if we'd set up wobble rooms and if they're being utilised. Wobble rooms, for those who don't know, is a sort of de-stress area to go when things are getting on top of you, essentially. And, you know, certainly it's a stressful time for everybody. Natalie and Helen, do you have any, and Mark, do you have any any comments on how you're managing emotionally with this time?
We're lucky that our trust is very supportive, and they've always been quite supportive of all their doctors and dentists in training, and they've turned our academic atrium into a rest area. There's a ping pong table, and they come and we have breakfast delivered twice a week. We have groceries in our canteen. The only staff can access the canteen, and so we can go pick up our eggs on the way home. And there's a butcher that comes twice a week, and you can buy stuff off them. They got a delivery of 4,000 Easter eggs this Easter. So there's lots of coordination within, not just from the trust support, but the local community, and so supporting the staff who are working on the front line. And we have regular updates of other things that we can access for our health and well-being. So like apps like Headspace are doing free access for NHS staff, and other well-being offers. We get basically a daily email from our postgraduate team signposting us to these resources to help us manage our own stress and our well-being in this time.
Thanks. We've had a question from Kirpal Banara, who is asking about, which I might be able to answer actually, advice on orthodontists who want to be redeployed. Any news on urgent care centres having ortho equipment to deal with ortho emergencies? Well, I can only speak about the Midlands, and I'm one of the regional advisors through the Midlands. And in the Midlands, there are no plans for any urgent care centres specifically for orthodontics. But the aim will be that certainly any orthodontist that wants to volunteer can. In fact, the whole of my team have volunteered. And the aim would be that certainly we would be available should there be an orthodontic problem in either a localized hot or cold site. So that's the Midlands. Obviously, there may be differences in other parts of the country and indeed internationally, but hopefully that helps a little bit on orthodontics in the wider Midlands region. I don't know, Natalie and Helen and Mark, whether you've got any comments on that from your regions.
Yes, we have, with collating the information for our specialist and secondary care centres to link into these hubs. We have kind of in discussions with our local orthodontic managed clinical network as to how that we would get any orthodontic input into these urgent hubs. It's expected there's going to be very few true orthodontic emergencies, that patients would directly contact their orthodontist if they were to have a problem for advice over the phone, but if needed, our MCN can help and kind of tie into these hubs when they're needed, if there are some patients who turn up who need to be physically seen.
And on from that, colleague Bassam Ali Al-Tuhrairi, apologies if I've not got your name right, from Iraq, who's asking and saying there will be a huge number of orthodontic patients. What are the plans for them after the wave subsides? Any ideas as to how we can arrange the scheduled visits? Well, that is something which, again, we've been discussing. I think the reality will be longer hours and patients who are more spread out in terms of their appointments, following the guidelines. And I've certainly not got anything more than that, but I think there's going to be, not just in orthodontics, but across the board, a huge number of patients who will require probably a lengthening of the working week in order to sort of help and support them.
When we hear discussions on ending the COVID period, it's often talked about that it'll be young people. They'll start by opening primary schools and secondary schools, and maybe, Richard, that you get your orthodontic patients back first.
It could be. It could be. Yeah, and I think we're coming towards the close of the timeline that we've got. First of all, I would like to thank all of our panelists and also all of our participants. Apologies that we haven't been able to get through all of your questions, but what, as Ian has said at the outset, we'll try and do is to sort of maybe collate some that we may be able to answer going forwards online. Basically, we've, I think, heard some very enlightening information from all of our panelists about, from starting with Helen, from skills assessment right at the start and the training of staff who were likely to be deployed, starting with junior members of staff and then on to more senior ones, and how they fitted onto the patient journey. Natalie has told us about her own particular experiences so far in terms of involvement, and the fact that some of the issues obviously still revolve around getting appropriate PPE, and I think that's well recognised throughout certainly the UK. And Mark, it's been very helpful to hear from you about what's happening outside the UK. So my thanks go again to all of the panelists and all of you that have sent in questions, and please let us know as to how successful this has been, and I think we would be happy to set up future webinars either on this topic or others going forward. So many thanks to everyone, and stay safe, everyone.